Well, hello, everyone. Welcome to our program tonight entitled Optimizing Patient Outcomes in Bipolar Disorder, Long-Term Management of Major Depressive Episodes. I'm Dr. Joseph Goldberg. I'm a clinical professor of psychiatry at the Icahn School of Medicine in Mount Sinai, New York. And it's a pleasure to be with you this evening. I am joined by my colleague, Dr. Roger McIntyre, who's professor of psychiatry and pharmacology at the University of Toronto in Toronto, Ontario, Canada. And these are our disclosure statements. We are going to be speaking tonight about clinically relevant information in the assessment and management of bipolar disorder. And to frame up our discussion, we have Dr. McIntyre's disclosure, we have my disclosure. To frame up our discussion, I'd like to give us an overview of some learning objectives for tonight. So first, a goal to formulate a differential diagnosis of major depressive episodes associated with bipolar disorder, let's call that bipolar depression, principally by differentiating bipolar depression from unipolar depression, or what we call major depressive disorder. Secondly, to propose appropriate and effective treatments for bipolar depression. Thirdly, to integrate strategies for treatment of patients with bipolar depression and physical and psychiatric comorbidities. And then finally, to apply management and patient education recommendations and current clinical practice guidelines to routine care of patients with bipolar disorder. So over the course of tonight, we'll be addressing each of these. We're now going to shift our attention to some pre-test polling questions. And for that, I'm going to invite my colleague, Dr. McIntyre, to take us through these polling questions. Dr. McIntyre.
To work with you again on this project. Just trying to advance the next slide for the pre-test. Can that be advanced for me? Okay, first question for us all is, how confident are you in the management of patients with bipolar disorder in your practice? Very confident, confident, neutral, less confident, or no confidence? Okay, we'll give you a few moments here for your answers. Thanks for your responses. And we'll come back to these at the end for the post-test questions. Thank you. So Joe, 75% or so are saying they're neutral, and we don't have any mail-in ballots. So this is what the vote stands as. Next question. Okay, which of the following was required to make a diagnosis of bipolar depression? Family history of psychiatric disorders, history of hypomania, somatic complaints, symptom onset prior to the age of 25, or unsure? It's an interesting question. A little more. I think this question probably provokes some conversation. Okay. Okay, Joe, 75% of our colleagues would put their money on history of hypomania required to make a diagnosis of bipolar depression. Thank you all for your responses. Now we'll look on to the third pretest question. Here we go. Okay, which approach to treating bipolar depression is endorsed by all of the major guidelines? Avoid antidepressant use, antidepressant monotherapy, avoid SSRI use in particular, SSRI monotherapy, or unsure? Okay, this one's a bit more distributed. This is interesting. Half of people, the modal answer is avoid antidepressant use, but we've also got a significant representation across other options. So we'll look forward to coming back to that one as well. We do cover this during the program. Okay, our next pretest question. What is the risk of manic or hypomanic switch when treating bipolar disorder with lurasidone? Limited, minor, moderate, significant, or unsure? Risk of switching when treating bipolar disorder with lurasidone. Okay, This is interesting. So I'll even call that bimodal. It's not quite, but limited. The modal answer was limited. And then the next cited or next selected was moderate. So interesting. We'll have to reflect on that during the program. Okay. I think that's the last one, if my count is correct. Oh, one more to go. Yeah. A 23-year-old patient with bipolar depression is experiencing an bipolar disorder is experiencing an acute bipolar depressive episode. The patient had a history of alcohol abuse and experienced manic episodes when treated with antidepressants prior to the bipolar disorder diagnosis. Should you be concerned about the patient's risk of attempting suicide? And the options are listed there. Yes, no, need more information, or unsure. Should you be concerned about a risk of suicide attempt? I think we're seeing a consensus so far on this one. Okay, I think that's unequivocal in terms of where people have placed their answer on yes, Joe, 100%. Hard to beat that. Okay, and I believe that's our last question. Oh,
no. Just what you thought we were done.
Okay, I thought there was just 4 or 5, but okay. We've got about 50 more questions, actually. Jim is a 35-year-old male with bipolar disorder, reports he doesn't like to take his prescribed medications because it reminds him that he is sick. We hear that not infrequently from our patients. What would you suggest to improve Jim's adherence to his prescribed regimen? Considering an LAI, a long-acting injectable antipsychotic, establish a routine around taking his medications, put the pill boxes in obvious locations, strengthening his perceptions about treatment benefits, or unsure? Okay, looks like our modal answer we got is coming in. Establish a routine about taking his medications. And the other two are equally divided between an LAI, long-acting injectable, and strengthening belief systems, perceptions about treatment benefits. Okay. Thanks for participating, folks, in these pre-test questions. We really appreciate it. Okay, so I think at this point, Joe, it's either over to you or we're going to sit and we're going to watch the video now play. We'll come back during the post-test.
Yep. So let's get on with our presentation, and then we'll come back and look at these on the back end.
You bet. Look forward to it. Thanks, everybody.
All right, so let's begin by talking about improving accurate diagnosis of bipolar depression. To start, what is bipolar depression? It's defined by having a major depressive episode, the same as in unipolar disorder, but in addition, other times in the patient's lifespan where they've had manic and or hypomanic episodes. So people with bipolar disorder often don't have an awareness or a sense of insight about their symptoms with regards to the manias or the hypomanias. It is truly a kind of an anosognosia, meaning a lack of awareness of the presence of illness. And so they may not report manias or hypomanias as pathological deviations from their norm or as clinically relevant phenomena. It really means we have to delve in and get some clarity in going through someone's past history about a change from their usual state when they've had high periods. Patients, by contrast, often do have much greater insight about the presence of depression symptoms. And so it's often been said patients come to treatment when they're depressed and are brought to treatment when they're manic. So part of the clinical challenge is really teasing these things apart. So let's talk about some of these stages and phases of the illness. We know from longitudinal follow-up studies that if you count up the time spent with mood symptoms in people with bipolar disorder, the predominant amount of time spent involves the depressed phase of the illness. Studies from the NIMH Collaborative Depression Group and others tell us that half or more of the time spent with mood symptoms involves down periods. And we can talk about manias or hypomanias. On the graphic you have before you, you can see some of these data telling us about a fifth of the time is often spent with mania or hypomania. And then mixed features. In the DSM-4, that was a little more narrowly defined as a full syndrome of mania with a full syndrome of depression. In a bipolar 1 disorder patient, now in DSM-5, we more broadly speak about mixed features as involving the syndrome of, say, depression with even some elements of the opposite pole, or vice versa, a syndrome of mania or hypomania with some elements of the depressed phase of illness. And that turns out to be somewhere between a quarter to maybe as much as a third of patients. And then lastly, we can see this notion of rapid cycling. It's a course specifier defined as 4 or more episodes over a 12-month period. So we don't talk about rapid cycling on a day-to-day basis. That would be more pertinent to mixed features, but we do talk about multiple episodes over time, and that seems to be about 15 to 20% or so of people with bipolar disorder. So if we ask people with bipolar illness how they feel about their quality of life, their functioning, their overall sense of well-being, we see that compared to the general population, individuals with bipolar disorder, particularly in the depressed phase, will identify reductions in their overall sense of physical health and well-being, as well as in their sense of mental health. So this pertains to the depressed phase, but it also speaks to the ways in which depression leaves its scar or its mark, so that even when someone has recovered from the depressed phase of bipolar disorder, they may continue to have difficulties in functioning and outcome. And it's not simply a function of a current syndrome of depression. Our next slide looks at this severity of depressive symptoms and its impact on functioning. Some very interesting data here that speak to the ways in which it's not just syndromal depression that interferes with functioning. So on this graphic, we see on the right-hand side, syndromal depression has a very high correlation with functional impairment, diminished overall life satisfaction, and so forth. But as we turn to the left, we see subsyndromal depression symptoms. That means not enough intensity and severity and duration to meet the DSM criteria for a major depressive episode. Even low-grade depression takes its toll. And then even still to the farther left, when depression has resolved, we still may see functional impairment in people with bipolar disorder. So depression is clearly a contributing factor. It can leave its mark. And in many ways, even though someone may be syndromally recovering or remitted from depression, they may not be functionally recovered. When we think now about the burden of bipolar disorder, and in particular with regard to the role of depression over time, the most catastrophic of outcomes would count as suicide. It remains the leading cause of death in people with bipolar disorder, a 15 to 30-fold higher likelihood of someone with bipolar disorder dying from suicide as compared to the general population. Usually goes hand in hand with depression, although note, mixed features can sometimes play a role in this as well. So the full syndrome of depression is more often present than absent, but some authors have observed that when there's even low-grade mixed features, agitation, restlessness, impulsivity, some have described this as sort of the jetpack that goes on top of depression that may drive the likelihood of acting on suicidal thoughts. We can't predict suicide. We can identify risk factors such as younger age, earlier age and onset, severity of depression. One study we had done in the NIMH STEP-BD program some years ago found that an increasing number of depressive episodes was a correlate of suicide attempts. And having made a prior suicide attempt, if one had to pick one symptom that probably has some of the most robust predictive value, is the likelihood of having a subsequent attempt, if not a completion, in someone that has made a suicide attempt. This has been and remains a substantial public health threat. So all-cause mortality is increased in people with bipolar disorder, not just though from suicide. If you have bipolar illness, your likelihood of an early demise is at least twice as great as that of people in the general population. That means if there's a medical condition such as a malignancy, an inflammatory disease, an infectious disease, cardiovascular disease, accidents, diabetes, all of these events increase the likelihood of premature death in people with bipolar disorder. Hence the observation that people with this illness will have a shortened lifespan by anywhere from 10 to 20 years because of one or another of these factors. All the more important then to try to make as accurate and prompt a diagnosis as possible, not just because it's the right thing to do, but if we think about some of the complications and burden of illness over time, if we can intervene early and appropriately, it's conceivable we might actually forestall and prevent some of the downstream complications that occur. So this is where things get challenging. Many of you are probably aware of studies that have for some time now informed us that people with bipolar disorder report that Often up to 10 years may go by from the time they first have symptoms to the time that they actually receive a diagnosis of bipolar disorder. One of the fundamental questions is the misdiagnosis of bipolar disorder as major depressive disorder or unipolar depression. That's shown on the left-hand triangular shape here. About half of people may have a diagnosis of major depressive disorder. But it does get tricky because most people with this illness will have a depression before they ever go on to have a mania. And so unless you have a way to predict the future, someone who comes to you in a major depression, whom you have screened for a history of mania or hypomania and does not report a history, until time proves otherwise, has unipolar depression. I think a key point, and Dr. McIntyre might want to comment on this when he's speaking as well, is we don't just go by symptoms. So we're really building a story here. And we think about age of onset being younger in someone who's predisposed to bipolar disorder, someone with a family history of first-degree relative, not just of bipolar disorder, but of highly recurrent mood disorders of any kind, or a family history of suicide, or a family history of psychosis are all increased risk factors. The course over time also tends to be telling. So in people with bipolar disorder, depressions constitute a large amount of the time spent with mood symptoms, but they're often not persistent and chronic as they often are in unipolar disorder, but they're more punctuated and punctate. You'll have a depression, then you'll have a waxing and waning course. There'll be some degree of remission, then it comes back. It's a come and go phenomenon. So part of the misdiagnosis has to do with failure to screen for a history of mania or hypomania, and part of it also has to do with knowing someone's overall risk factors. Then on the right-hand side of this slide, we talk about other potential misdiagnoses such as anxiety disorders, schizophrenia, personality disorders, and so on. And here too, I think part of the challenge is knowing when are these wrong diagnoses, or when might these be comorbid diagnoses if one is feeling different parts of the elephant. And in this case, bipolar disorder is very heterogeneous in its presentations. Most people with this illness have other psychiatric ailments or medical conditions as well. So anxiety disorders and substance use disorders are common comorbidities. And the real challenge for the diagnostician is teasing apart whether there's one diagnosis, multiple diagnoses, and sussing out the hierarchy of these things. So misdiagnosis can certainly have significant consequences. It may lead to the wrong treatments. It may lead to persistent symptoms and further mood destabilization over time, as well as forecasting the wrong diagnosis. So now we have some information about just differentiation between major depression, bipolar 1 and bipolar 2 disorder in someone who does present with a major depressive episode. And again, a major depressive episode syndromally, symptomatically looks the same in people with unipolar or bipolar disorder, or for that matter, in schizophrenia or in panic disorder. A major depression is a syndrome. It's not an overarching diagnosis. An MDE can happen in various ailments. So once we've identified a major depression as present, we do need to get some longitudinal perspective about a history of mania or hypomania. By definition, in major depressive disorder, formerly known as unipolar depression, there's never been a history of a mania or a hypomania. In bipolar 1 disorder, the DSM-5 actually does not require, actually just became aware of this recently, does not require that you have to have had a depression, but it's more likely than not that you will. You do have to have at least one manic episode to get membership in the category of bipolar 1 disorder. In bipolar 2 disorder, you have hypomanias, that is the same symptoms of energy and sleeplessness and expansiveness, but they don't cause trouble. By definition, they don't lead to psychosis, they don't lead to hospitalization, so they're easier to miss, as you can imagine. And you've never had a manic episode in bipolar 2 disorder. There's no such thing as a bipolar 2 mania. If you have a full-blown mania, that's conversion to bipolar 1 disorder. The ratio of time spent with depression to highs is about 3-to-1 in people with bipolar 1 disorder. In bipolar 2, it's nearly 40-to-1. So depression is the dominant mood symptom and state that we see, and we have to be very meticulous in sussing out these other elements to make an accurate diagnosis. On this next slide, an overview of clinical differentiation between bipolar disorder and major depressive disorder. Listed a few more of the things that I touched on before, such as early age at onset, especially early adolescence, is not a giveaway for a bipolar diagnosis, but it's a little more consistent with the bipolar than a unipolar diagnosis, which tends to occur later. Family history is not a slam dunk. If you have an identical twin with bipolar illness, that does not mean you will have it. It's not Mendelian genetics, but a first-degree relative does increase the likelihood anywhere from 10 to 25%, depending on the study you see. In major depression, you don't have hypomanias. You can have what are called mixed features. DSM-5 throws us a bit of a whammy here in saying you could have low-grade symptoms of hypomania, but never meet the definition of a syndrome of hypomania or mania in someone with major depression. That would be called major depression with mixed features. But once you've met the definition of a syndrome of hypomania or mania, that's bipolar disorder. Hypersomnia, hyperphagia, so-called atypical depressive symptoms can happen in either unipolar or bipolar disorder, but they're somewhat more likely in bipolar patients. And then this episodic, of course, as I mentioned, is more often seen in bipolar disorder than unipolar disorder. And Roger's now going to talk to us about considerations for screening. Roger.
Well, thanks, Joe. That was incredible. And to pick up on that point you made a moment ago around the dominance of depressive symptoms, more common at the initial presentation and also during longitudinal follow-up. And the message, Joe, I think is loud and clear. We should screen for people who are presenting with depression at the initial consultation. And as well, if the person does screen negative for bipolar at that initial consultation, and the working diagnosis, for example, is major depression, if your patient is not benefiting from conventional approaches to major depression, I think that's the clarion call to maybe revisit screening. So I would say screening at the initial consultation and periodically, if in fact the outcomes are not favorable for the patient. Joe, as you know, we have had many screening tools that have been made available to us. In fact, there's over half a dozen screening tools. There are some features of a screening tool that would really make it more applicable. They need to be brief, self-administered. They should be sensitive, and they should have what's called negative predictive value. In other words, if someone screens negative, you've got a good confidence that they don't have bipolar. And those features, brief, self-administered, sensitive, good negative predictive value, would describe, for example, the MDQ, which we've had for the better part of the last 20 years or so. And this is a tool that patients would complete in the waiting room. A really important point for everybody to remember, screening tools don't diagnose bipolar disorder. They raise your level of suspicion. Now, just recently, Joe, I was involved in a survey, and we asked care providers across America, could you maybe name or are you familiar with screening tools for bipolar? The great majority, more than 80%, could name at least one. And then we asked, how often do you use them? And only about 25 to 30% of people said they use them. That's a gap between what the knowledge is and what's being implemented. And then some quick queries were, people often said it did not make my job easier. There were other reasons as well. There were some concerns about false positives, things like that. So there's other screening tools. One I want to introduce is the Rapid Mood Screener, free of charge. It has some of the features we talked about that you want to see in a screening tool. But also in the Rapid Mood Screener, in addition to phenomenology, Joe, we also have longitudinal course characteristics, age at onset before age 18, number of depressions, response to antidepressants. My experience has been these are high yield questions, raising or decreasing your suspicion around bipolarity, and they're captured in the Rapid Mood Screener. Joe, you also alerted us to so-called validators of bipolar, like family history, etc. Let's just say a couple more words about phenomenology. As you said, Joe, there's no one feature of the depression that is pathognomonic or diagnosed as bipolar disorder. So it's about building the case. And one of the aspects that we discovered in our sample, which we shared with Cleveland Clinic, was that a very large percentage, about a third of people who have depression as part of bipolar disorder will present with mixed features. That is, they will have sub-threshold hypomanic symptoms during the depressive episode. The DSM-5 is very specific on what it allows for, the so-called mixed feature specifier criteria. As clinicians, we need to balance specificity with sensitivity. What are the most common manifestations of mixed in the real world, in the clinical ecosystem? It's what I call the 4 A's. When someone comes to me and says, I'm depressed and I have anxiety, I'm agitated, I'm really angry and irritable, and I cannot pay attention, that gets me suspicious that they possibly have underlying mixed features. Interestingly, and you know this, Joe, none of these 4 A's are actually in the definition of mixed features, but they are some of the most common experiences of people who have mixed features. Keep in mind that screening does not supplant, in other words, it doesn't replace a careful clinical interview. These screening tools have good negative predictive values. You've got good confidence if they screen negative, but they screen positive, it's time to roll the sleeves up and delve into some of the course of illness variables that Joe had made reference to. And it stands to reason if we can detect and diagnose sooner than what Joe had described, this long 8-10 year span, that will allow us to initiate guideline concordant, evidence-based, and certainly in many cases FDA approved treatments that give patients a better chance for success. Now, with that in mind, with respect to what Joe and I have covered, just a quick case. This is Sue. She's 35 years old. She presents with depression. She's sleeping a lot, has hyperphagia, fatigued, has that terrible fatigue. Diagnosed with depression since adolescence. She's been on a set of treatments. You can see SSRI monotherapy, when she was initially diagnosed with major depression. It was not effective for her. Had a history of hypomania, according to the chart, and has been hospitalized for mania in the context of taking antidepressants. And there may be some misuse of alcohol in the past. Questioning of her reveals that there may be a family history of bipolarity. So when you see a case like this, and in part your life's made a little bit easy because you've got the history of hypomania or mania. But for me, what I'm always trying to do, especially in patients who present with depression, what's the age of onset? Remember, 75% of people declare bipolar disorder observably before the age of 25. How many episodes have you had? You know, Joe, for patients who are female, I'm especially paying close attention to depression onset and recurrence during pregnancy or postpartum as an example, listening for the phenomenology of the 4As, maybe atypical features, hyperphagia, hypersomnia, maybe psychosis, and of course, response to antidepressant. And as Joe mentioned, comorbidity is the rule, not the exception. 90% of people with bipolar disorder have one comorbidity, 50% have 3 or more, so-called polymorbidity. And what's interesting is that at first presentation in late adolescence, early 20s, comorbidity is less prevalent than it is after someone's had 3 to 5 episodes. Another reason why we want to detect and diagnose and treat early to forestall and prevent accumulation of other concurrent conditions. Now, I wonder if I can just segue now into the treatments. And if Joe and I had about 3 hours of time, we'd be able to get into a lot of the granularity here. But what I've done in this slide is provided a playlist. In other words, these are the treatments that are either currently FDA approved and or proven effective across the phases of bipolar, acute depression, acute mania, and maintenance. And what you can see, what we're focusing on today, bipolar depression, that playlist does have a lot of options. We've got relatively fewer options, for example, to mania. We have, for example, cariprazine. We have lurasidone in monotherapy or adjunct. We've got quetiapine and olanzapine fluoxetine, all FDA approved in bipolar depression. There's additional treatments that are also efficacious in bipolar depression and or find themselves as recommended in clinical practice guidelines for the treatment of acute bipolar depression, but they're not FDA approved in bipolar depression, at least not currently. Now, the clinician at the point of care needs to always balance what's the benefit, what's the burden, in other words, what's the side effects, what are the safety concerns, what's the cost, how easily can I have access to this medication. And these are decisions that take place at point of care. They're shared decisions with patients. But we do know that lurasidone's indication is both as monotherapy as an adjunct to lithium and valproate. Quetiapine is approved as a monotherapy. Olanzapine fluoxetine, by its very definition, is a combination pill in bipolar 1 depression. And cariprazine is approved also in bipolar 1 depression. One other aspect about this is antidepressants. There's been a number of surveys in the last 5 to 10 years, and a recent one in 2020 that indicated that antidepressants in bipolar disorder are commonly prescribed. And what's really interesting, Joe, and you know the study that came out in 2020, that antidepressant monotherapy seems to be common practice. Now, we in fact do not have FDA approval for conventional antidepressants in bipolar 1 depression or bipolar 2 depression, and the evidence base supporting their efficacy, to say the least, needs to be augmented. It's not really a compelling database around efficacy. I think most clinicians are aware that there's a risk of destabilization, the number needed to harm. We'll get into that very shortly.
approaches 150 to 200 in some surveys. So destabilization is a risk, but not really the major risk for most people. Inefficacy seems to be the most common outcome with conventional antidepressants. And generally speaking, in bipolar 1 depression, we really, in fact, discourage antidepressant monotherapy. In some situations, they may be adjunctively administered with other agents that have the capability of stabilizing mood, like a lithium or some of the select second-generation antipsychotic agents. When we select a treatment, we're always trying to select a treatment that gives patients the best probability of success. The effects of these medications that are studied in clinical trials are often presented as a p-value. And p-values matter because we have to show statistical significance. But you and I are not treating patients to a p-value of 0.05 or 0.01. We want our patients better, and we don't want side effects. That's the calculation. And so there's other ways we can express effect sizes. Maybe some people would be familiar with what's called Cohen's D scores, where you look at the overall magnitude of the effect of the intervention expressed in a number. One other way that we often think about expressing effect sizes is so-called number needed to treat. So in other words, how many people do I need to treat before I see the outcome I desire? The perfect treatment is 1. Every patient gets better. So NNTs of 1 is perfect. Now, there are benchmarks, and the benchmarks that the field has adopted is that when the NNT is less than 10, that's thought to be clinically significant. How about number needed to harm? Well, in an ideal treatment, I want number needed to harm to be infinity. No one gets a side effect. Doesn't exist. So number needed to harm is also benchmarked at 10. We like to see number needed to harm greater than 10. So one way to think about effects of treatment is to look at the NNT. Is it less than 10? That's clinically significant. And is the harm greater than 10? That's also clinically significant. And what we're really doing when we do this is we're really conducting a calculation, which is otherwise known as effectiveness. What is the benefit? What is the potential for harm? And we integrate these together. And this is part of the shared decision making that we do with our patients. And it's, I think, really for us as clinicians, when we're selecting treatments for bipolar depression, ask yourself, what is the NNT and what is the NNH? And that might guide treatment selection and how you sequence.
So this is so clinically useful and important, Roger, to bring it home. Can you imagine if a patient's undergoing general anesthesia and the anesthesiologist is putting the mask on and says to them, you know, about every 10 people that I treat, one of them goes to sleep when we do this. I mean, I want an NNT of 1 if I'm undergoing a major medical procedure. We almost come to expect that. And yet throughout medicine, our NNTs tend to not be as perfect, really reliable as something like anesthesia might be. So the lower, the better. And when we're comparing treatments, as you point out, Roger, a p-value says the event that I've seen in a study is significantly different from what I would see by random chance. That tells me it wasn't a fluke, but it doesn't tell me how much better things are. And these concepts of NNTs or effect sizes tell us how clinically meaningful something is. I could say this treatment's statistically significantly better than that treatment, but if it doesn't amount to a meaningful impact, it doesn't really help us. So we like single-digit NNTs to tell us closer to the anesthesia type of effect, so that if a patient says, what will I expect to see if I know a drug has a single-digit NNT, I can impart that information as a clinician and say, here's what is meaningfully different that you're going to see. It's interesting with antidepressants. I think you very astutely point out, we often worry about the NNH of switches in mood destabilization, which tends to be a triple-digit number. But the NNTs, at last count that I've seen, are in the order of about 30, meaning compared to a placebo, you've got to treat upwards of 30 people before you're going to get a success. And if I have a life-threatening illness, as we talked about at the beginning, I'd like to do better than that. So with that, our metrics, researchers measure depression symptoms, measure manic symptoms, measure outcomes such as blood pressure or cholesterol or blood sugars or changes in weight or somnolence. It's good to have some means of keeping track so we're not feeling subjective. If you're a practitioner, you might or might not be using a rating scale the way a researcher does. In research studies, the Montgomery-Åsberg Depression Scale is commonly used. When a study is done, we ask about the degree of change in overall symptoms over time, and that's a continuous measure. So something like Cohen's D will tell us a small or a medium or a very large effect. Or response, are you 50% better at least than when you started out? That's a useful parameter, but it's not the be all and end all. If I start out with a MADRS score of 40, which is very depressed, and I wind up with a MADRS score of 19, I'm a responder, but I'm still pretty depressed. So we really seek remission. That's where, if any symptoms are left over, they are near minimal as far as any clinically meaningful effects go. So scores here would be scores of like 10 or 12 or less. And for numbers needed to harm, the main outcome measures that we think of are described on the slide that talks about outcomes of interest in studies. So substantial weight gain, sedation, and extrapyramidal side effects, and so forth. So let's have a look at what the 4 FDA-approved treatments for acute bipolar depression tell us as far as response rates and remission rates using these concepts of NNT. The lower, the better. And for those who want to calculate these things at home yourself, not hard to do. You take the response rate in the treatment group and the response rate in the comparator group, that might be the placebo. You subtract the comparator from the active drug, and then you take the inverse. So 1 divided by the response rate in drug minus response rate in comparison or control, and you get the NNT, and that's shown on this slide with cariprazine, lurasidone, quetiapine, or olanzapine fluoxetine. The lower, the better. So olanzapine fluoxetine has an NNT of 4, much better than 30, right? Quetiapine 6, lurasidone 5, and cariprazine just coming in at an NNT of 10. So these are all not just significantly better than a placebo, but clinically meaningful. We could say to the patient, I expect to see a fairly high probability of you reaching response. Remission, this more stringent outcome, mirrors what we just saw. So on this next slide, this Montgomery-Åsberg score remission, scores of 10 or less or 12 or less, depending on the study. We see pretty much single digits, lurasidone, quetiapine, OFC, cariprazine just slightly over that number of 10 that we'd like to be the upper cutoff. So these are all compelling, statistically significant, and clinically meaningful response and remission rates where we're treating bipolar depression. But as you mentioned, Roger, everything is a balance. We're always balancing benefits with risks. So on this next slide of a benefit versus risk analysis, courtesy of our friend and colleague Leslie Citron, we have listed for you on the left-hand column common adverse effects that we think of with the medicines that are FDA approved, such as weight gain that's significant, meaning more than 7% of where you started from, motor side effects, somnolence, nausea, and arguably most important of all is deal breaker side effects. Did you drop out because of an adverse effect? So-called effectiveness. I could have the best treatment in the world, but if people won't take it because they stop it because of a side effect, what good is that? So NNHs that are big and high, we like, and this is a color-coded so-called heat map. So green is good, and you can see examples here, lurasidone, cariprazine, lots of green, a little more intermixing with yellow and red, and you can sort of read these for yourselves in terms of getting a sense of what I might anticipate. So as you're gauging my NNT, and as you're gauging, well, what are the potential side effects and the commonness with which we see them, the higher the NNH, the better. This can be, I think, a very useful metric and tool for the practitioner in thinking things through with the patient. So the challenges with this illness, a lot of depressive illness burden, a lot of patients end up getting prescribed more than one medicine. And so this whole question of combinations of medicines can either be artfully undertaken where one is very craftfully, is that a word? Thoughtfully, mindfully putting together medicines that might be synergistic, such as a mood stabilizing drug with a second generation antipsychotic that has known antidepressant properties, or putting together complementary mechanisms of action. While monotherapy in some ways is, I'd say, an ideal, it's often an unrealistic concept, and it's almost a bit of an archaic concept. In complex medical conditions like cancer and hypertension and infectious disease, I've never met a primary care doctor saying, well, I'd really like to treat your severe hypertension with just one drug. I mean, that would be nice, but our colleagues elsewhere in medicine put together mechanisms of action that are complementary. So I think where our field now stands is when we favor combination drugs, it should be very thoughtful, non-redundant. And I like to tell patients, think of medicine regimens like personnel rosters, and everybody's got a defined role. Or if you like a sports team, so every member on the team has a job. You don't want duplication behind the mound or or in the outfield, you want to know this drug is here for this purpose, that drug is here for that purpose, and that we're always balancing risks and benefits. So as studies have gone, this next slide is actually a study that we had done in the STEP BD program, showing that about 2/3 of people with bipolar disorder coming in the door to STEP BD were taking combination therapy. Monotherapy was rare. And what we call the core treatments were remarkably not commonly being prescribed for these patients. And one thing that's not on this slide, which I always like to point out, is what I always thought was the takeaway of our study, was that one of the biggest predictors of the number of medicines being prescribed was how many depressive episodes you'd had in the course of your lifetime. So think about it. If depression is so hard to treat, practitioners throw the kitchen sink at it, and they think nothing of prescribing 3, 4, 5 medicines. We have a study coming out in one of the journals shortly. It did a big meta-analysis. About 1 in 3 bipolar patients will take 3 or more psychotropic medicines. About 20-some% will take 4 or more. And they're not always thoughtfully put together. So throwing down the gauntlet to our colleagues is when you put together combinations, to do so with great thoughtfulness about mechanisms and complementarity and avoiding redundancy. Roger's going to take us through some information about cardiovascular and metabolic comorbidities.
Well, thanks, Joe. And an amazing statistic, Joe, around the polypharmacy. And I always say that, bipolar has so much polymorbidity and also has so much polypharmacy. It's really quite striking. And as you said, it needs to be rational and complementary. And I'm going to segue into this area of metabolic and cardiovascular comorbidity. And I think that the relevance of this is abundantly obvious. Our patients have much higher rates of many of these pre-existing conditions like heart disease, pre-diabetes, diabetes, dyslipidemia, relative to the general population. And when you put this together in one group, so-called metabolic syndrome, the rates in our populations are much higher after you adjust for the usual covariates of age and things like that. What's interesting, Joe, is that we've heard so much during COVID about pre-existing diseases and how they put people at risk of being infected with COVID and having complications. And we have a paper in JAMA where we looked at mood disorders and found that people with mood disorders have an increased risk of being infected with COVID and having complications. That risk survives. In other words, it exists even in the absence of obesity and diabetes, but that certainly makes it worse. Now, when we step back, not only is there morbidity and risk with these cardiovascular problems, but also it is a cause of premature mortality. And cardiovascular disease is the most common cause of premature mortality in bipolar. And Joe, you mentioned that earlier, and this is entirely modifiable. There's actually some data now from Europe to show that if you're a first-degree family member who's not affected by bipolar, but your brother or sister does, you, the first-degree unaffected relative, do not have a shorter lifespan. So the shorter lifespan is the person who has the life lived with bipolar, and it's often driven by cardiovascular, and it's often preventable. Patients end up with these conditions for a host of reasons, social determinants like income and housing. And patients end up with these conditions for a host of reasons, social determinants like income and housing insecurity. Histories of trauma, we've shown, increases the risk of metabolic syndrome and bipolar, like sexual and physical abuse. And clearly for many patients, habitual inactivity, poor sleep, and really poor food choices, an unhealthy lifestyle. For other patients, no doubt about it, that medications contribute and are a modifiable factor. I want everyone to remember that not only does obesity have its hazards from the point of view of health and general well-being, but I always say, Joe, that obesity metastasizes to the brain. In other words, we see changes in brain structure in bipolar disorder in people who are obese. We see volume changes, structural changes, and we think this is why so many people who are obese with bipolar have more depression and have more cognitive impairment, in part because of these concurrent conditions. Now, when we talk about comorbidity, it's not just the physical comorbidities. That's certainly enough to keep us busy, much of which is modifiable by modifying risk, but also other comorbidities. And on what we used to call axis 1, in other words, mental disorder comorbidity, what immediately jumps out is anxiety disorders, substance and alcohol use disorders, ADHD, attention deficit hyperactivity, binge eating disorders, many as 1 in 5, maybe more. Women with bipolar disorder are conditions to consider, and that's not an exhaustive list. These comorbidities, along with the physical comorbidities, also are reasons why we end up seeing so much polypharmacy. When we're managing people who have bipolar disorder, I think increasingly we're being asked to not only think about above the neck and below the neck, but really the holistic patient. And I remember when I started as a psychiatrist, Joe, the mantra at the time was, you got to treat the comorbidity first before you can treat bipolar. And that mantra is stale dated. You have to really treat both conditions at the same time. Now, obviously, there's a bit of common sense. When you have multiple therapeutic objectives, one has to take a coherent and in many cases sort of phase approach. I'm going to target this first. Let's take care of that. Then we're going to take care of this. Then we're going to take care of that. And that's a reasonable way you work with people, in real world practice. But I think that the takeaway is, for me, Joe, has always been, coming back to what I said about screening, I was always taken aback at how different the rate of comorbidity is in people who are 22 or 23 with bipolar versus 35 or 45 or 55. They really accumulate comorbidities, much of which, not all, but much of which is likely avoidable by, in fact, integrated care management for people. Here's a case of Mike. Let's just talk about Mike briefly. He's 57 years old, presenting as so many people with bipolar disorder do, with a depressive episode, a full confluence of symptoms, and presents a narrative that we've heard so many times. That was, he was initially misdiagnosed. Now, I would say that in some defense of us as care providers, I'm going to blame Mother Nature. Joe, remember what we call transition. A lot of people present with depression. They have no hypomania or mania. I think it's a bit harsh to say that we misdiagnose them because Mother Nature is playing a game here. She hasn't shown mania or hypomania. So some patients, if you follow them prospectively, then they declare mania, hypomania. And so I call it the 1% to 2% rule. If you have 100 people in your office with depression and you say, come back in 10 years, that's a long follow-up time, but come back in 10 years, about 1% to 2% per year transition to bipolar. So quick mathematics, that's about 20 people now have bipolar. So bipolar is often covert, even in the cohort of people who present initially with depression. Watching out for these risk factors. Joe, when I started, I never thought that I would be at that first consultation speaking about diet, about sleep, about healthy lifestyle. And I mentioned in passing that physical and sexual abuse and other forms of trauma are not just common in our patients, but are also often predispose some of these other comorbidities, and that often needs to be addressed directly through psychosocial approaches. In the case of our patient, Mike, he's had concurrent conditions like cardiovascular disease and diabetes, and there are other considerations for him as well. But this is a very common situation. What treatment should I choose for this gentleman? What does the evidence say? To what Joe was presenting to us, what's the NNT, what's the NNH around key outcomes in terms of safety and harm that are relevant to someone like him? And unfortunately, I say unfortunately, these are common situations in our practice. Now, with respect to non-adherence to treatment, I think we all know this is a problem in chronic disease management. We're going to blame to some extent human nature on this. It's just what we are like. But this gets down into aspects of literacy, helping people understand their illness and their treatment, the benefits and the risks, concise, accurate information, psychoeducation, support longitudinally, where appropriate, evidence-based, manualized psychotherapeutic approaches. And I'm going to put a little plug in for peer support at the Depression and Bipolar Support Alliance. Peer support can often be a great resource for people around adherence and maybe demystifying some of the treatments that we often offer our patients. So with that, Joe, I'm going to pass it over to you in terms of best practices around patient education.
Now, Roger, I know you once thought about becoming a neurosurgeon. In my former life, I wanted to be a primary care internist. You really do think about the patient holistically when you come to think of not just what is their mood disorder, but what is the context in which this complexity arises. And as we're trying to strive for, as you say, the hierarchy of addressing comorbidities and really taking a very comprehensive approach, not just following an algorithm and saying, here's a diagnosis, here's a treatment. Real quick anecdote, you made me think of a patient I saw very recently with bipolar disorder, had been non-adherent with medicines, got depressed, started drinking heavily, and here's a COVID era issue. I'm seeing patients like many of us by telemedicine, and I asked him to check his blood pressure and put his hands out, and he's in florid withdrawal. And so how do you do a detox by telemedicine while trying to address his depression, and he'd like to stay out of the hospital. It's a challenge, but it can be done, and we just have to sort of take a very comprehensive approach. And I think the Therapeutic Alliance plays a role here as well in telling the patient, I'm here to take care of you, all of you. So let's get you back on track. Let's get you medically safely through the comorbidity of your alcohol use. Then we'll address the depression. Let's get you back on track. So this brings us to these essential clinical tasks in optimal care: engaging patients in treatment, retention and with adherence, restoring function, symptom control, relapse mitigation. These all speak to these concepts of really taking care of our patients as healthcare providers and not just narrowly focusing on, here's your MADRS score, you have a depression, let's take it away, but rather recognizing your adherence may be jeopardized by treatments that cause very low NNH adverse effects that neither you nor I is interested in seeing you have, which could downstream make things worse because of cardiovascular morbidity and mortality. So it really does take a mental village to keep in mind all these features. I find that engaging the patient in this shared decision-making process makes this a vital element. So not just, here's what I think we should do, but I'll lay out options for patients, identify and prioritize what the goals are, make sure I know what their goals are. I saw someone in a consultation recently whose main goal was they wanted to lose 70 pounds. That was caused by a prior medicine that they took. They had a very complicated history. They had some options that were never discussed before. So I always like to ask patients, what are your goals? It's not just symptom control. It's not just relapse mitigation. It's all these things. And we need to make sure, almost in a kind of a motivational interviewing style, how to assure that we know what the patient's goals are so that we can hopefully bring these together. Chronic disease management. So the notion here that this is a lifelong illness that we try to put into remission as best we can. It can wax and wane. We want to be alert to the things that could make it more likely to wax and wane, such as non-adherence or patients who have adverse effects and may stop their medicines or otherwise deviate, or the comorbidities that can pop up. And then really a shared decision-making approach, empowering patients to be aware of the things that can make their condition better or worse. That also includes psychosocial things like sleep hygiene and recognizing the ways in which psychosocial stresses can aggravate their condition. Decision support, that is giving patients a sense of, here's what's been shown to be useful for your condition, and let's you and me together discuss the pros and cons. It does take a village, so I think having involvement from family members, for that matter, assessing that there is a supportive home environment is also part of assuring optimal outcome. And then also treating patients within the context of their broader healthcare conditions. That often means collaboration with other mental health or general medical practitioners as well. So we've covered a lot in a short span of time. Let me summarize some of these points and then we'll wrap up. So accurate diagnosis is critical to optimize outcomes, prevent the use of inappropriate medicines, medicines that may not be efficacious, medicines that might even increase the risk of mood destabilization or fail to avert horrific outcomes such as suicidality. Screening tools are, as Roger pointed out, screens. They are starting points that will cue you as the practitioner to know where to delve in, the mood disorders questionnaire being an example, the more recent rapid mood screener being another. And if a patient scores below the threshold, Roger alluded to this notion of the negative predictive value. If someone scores below, pretty low chance that this is their ailment, on to one of the other 312 diagnoses that exist in the DSM-5. So we're really doing comprehensive assessments. At present, we have 4 FDA-approved treatments for the depressed phase of bipolar disorder. They vary in their risks and their benefits. Their NNHs, their NNTs are all rather favorable. So we have the option now to identify patients' characteristics. Roger, you call this deep phenotyping the patient. I always steal that phrase of yours, so we can individualize or tailor the treatment to the patient. Knowing this is a lifelong condition, so we need to know what the patient's goals are so we can maintain stability. And we want to get patients to become psychiatrically boring. That is the highest pronouncement I can make, where this illness goes into remission and then we let you live your life while paying attention to the medical aspect of things. We've talked about cardiovascular, metabolic correlates of this condition and the role for collaborative care. Thank you all for your attention, and we're going to move on to our questions and answers. All right. With that, We are going to revisit those initial questions that we saw at the very beginning and have a chance to re-evaluate your answers compared to what you'd said before, and then we have some live Q&A. So let's see if we can go to the first question. You've seen these before. It's not deja vu. Well, it is deja vu. So which of the following is required to make a diagnosis of bipolar depression? Is it a family history of psychiatric disorders? Is it a history of hypomania? Is it somatic complaints? Is it symptom onset after age 25? Or is it, I'm not sure. And we're letting you see your prior answers too. Let's see. So it looks like we have unanimity and 100%. So yeah, to make a diagnosis of bipolar depression, you have to have a history of either a hypomanic episode or a manic episode. So in a bipolar 2 depressed patient, you'd only have a history of a hypomania. If you have a history of a full mania, that would be bipolar 1 depression. And all these other elements that are mentioned, family history, history of hypomania, age at onset, are all sort of relevant corroborators, as we talked about in the presentation. Having a family history of bipolar disorder is certainly corroborative and supportive. And there are other psychiatric conditions besides bipolar disorder, such as a family history of highly recurrent depression, or a family history of suicide, or a family history of psychosis. Even a family history of panic disorder can run in bipolar pedigree. So it's informative, but it's not diagnostic. Early age and onset is actually common with this condition. So it usually strikes in late adolescence, young adulthood. Again, we're not just looking at the cross-sectional symptoms, we're looking at the totality of the presentation. Let's have a look at the next question. Which approach to treating bipolar depression is endorsed by all of the major guidelines? Is it avoiding antidepressants? Is it using antidepressant monotherapy? Is it avoiding SSRIs? Is it SSRI monotherapy, or is it unsure? And it looks like everybody is endorsing avoiding antidepressants. Roger, I'm going to ask you if you like this question or not. And you probably know why I'm asking if you like this question. What do you think?
Yeah. You know, I think that avoiding antidepressants to me seems so unequivocal, so categorical. I think that if you look at most guidelines, CPGs for bipolar disorder, antidepressants actually exist. They're just not the first line recommendation. They're often down the list. And there's a lot of additional clinical considerations to think about before you actually implement the antidepressant. But the full out, canceling of antidepressants, we haven't seen canceling of antidepressants yet. But I think that, so the question is very categorical. But I think there's some nuance to it.
Yeah, so this question is really meant to make you think. All right, it's one of those. There was a consensus statement by a bunch of bipolar experts about 7 years ago published, and many points did not reach consensus, but one that did was antidepressant monotherapy is probably a no-no, certainly in bipolar 1 depressed patients. Yeah. If I was writing this question, I'd probably say avoiding antidepressant monotherapy would be a hard justification to use that. And as you point out, antidepressants have their role. It's just they haven't been shown to robustly work. So they're really not first line on an overall basis. Let's go on to the next question. What is the risk of manic or hypomanic switch when treating bipolar disorder with lurasidone? I have to confess, I'm not sure the word limited. I assume limited, this is an ordinal sounding scale. So my English is my second language. I just don't have a first language, but I assume limited means next to none. So it looks like we have a majority indicating whatever limited means and some saying moderate. I find the responses to this question very interesting, even if you don't know exactly what is meant by limited by inference. So the randomized double-blind data with lurasidone, really demonstrate no signal of an increased risk of switch compared to placebo into mania or hypomania, which really speaks to what some might call the mood stabilizing antidepressant properties as demonstrated with this drug. One of the hazards with traditional antidepressants, let's call them, is the potential for switch either in the short term or the long term cycle acceleration. And our nomenclature needs an overhaul. But when we talk about a molecule that exerts antidepressant properties and mood stabilizing properties with an antidepressant component, that to my mind would imply a minimal to no, or I guess a limited risk of switch. So sorry, you moderate people, but lurasidone has not been shown to increase that risk. You want to add anything, Roger?
Yeah, I agree with what you said, Joe, and I just might add that we're focusing on bipolar depression tonight, but just to speak to its close cousin, major depressive disorder with mixed features, there was a study with lurasidone in that population as monotherapy. And why I'm bringing it up is because that is the perfect assay to look at a switch risk, because these people already have subsyndromal type hypomanic symptoms, and against placebo, the switch risk was also not higher versus placebo. So that was a particularly, I think, opportunistic group to look at from the point of view of risk. We didn't see the risk higher than placebo.
Yeah, excellent point. And since many people with bipolar depression manifest some subthreshold hypomania symptoms, as studies have suggested, sort of adds to the concern, not just that you're treating bipolar depression, but that this notion of mixedness on a continuum is really what you're going after. So when we talk about molecules with efficacy, it's not just that we don't want to exacerbate existing low-grade mania. It's that we really want to target the depression without destabilizing things any further. It's a tough order. Let's go on to our next question. A 23-year-old patient with bipolar disorder is experiencing an acute bipolar depression episode. The patient has a history of alcohol abuse, and actually that would be alcohol use disorder, I think, in DSM, and experienced manic episodes when treated with antidepressants prior to the bipolar disorder diagnosis. Should you be concerned about the patient's risk of attempting suicide? Pre-test, you all said yeah, and post-test, all of you still say yeah. If I had to write this question, I probably would say, why should you be concerned about this patient's suicide risk? It's almost a given. And the answer I would put is because he's got just about every risk factor you could think of short of having made a prior attempt. He's young. He has bipolar disorder, which puts his risk of suicide attempts or completions at 15 to 30-fold higher than the general population. Comorbid alcohol or substance use disorder is its own independent risk factor. He didn't have a good response to antidepressants before they were destabilizing for him. And so this is someone for whom you would be very concerned about risk, and you'd want to make sure you've got the right treatment. Right? So we can't do better than 100%. Let's look at our next question. Jim is a 34-year-old man with bipolar disorder. He reports he doesn't like to take his prescribed medication because it reminds him that he is sick. What would you do to improve Jim's adherence to his prescribed regimen? Would you use an LAI? Would you establish a routine around taking his medications? Would you put pill boxes in obvious locations? None of you thought that. Would you strengthen his perceptions about treatment, or not sure? Part of me wants to vote not sure, but I was never good at standardized questions. Roger, you want to take us through this one?
Yeah, this is a good question. Let's see what we got here. So it looks like the biggest answer is strengthen his perception about treatment benefits. Look, I think any intervention that strengthens a person's what's called literacy, health literacy, or treatment literacy is a win-win. People should know about their treatments and should know about their illness. So I would say, yes, I completely agree with that.
I would have to agree with your agreement. My only caveat is, so if his ambivalence has led to demonstrated non-adherence, you do want to probably bring up the concept of long-acting injectable antipsychotics, because non-adherence is a driving force for relapse risk. But there's a caveat to the caveat, which is that the two FDA-approved long-acting injectables for maintenance treatment in bipolar 1 disorder have been shown to prevent a future mood episode, but mainly prevent a future mania. And we don't really have good data to support the use of LAIs for depressions, partly because they haven't really been studied in designs that were meant to really bring that out. But so this is a more complicated question than we wish it was, but I would agree. Educational literacy, medication literacy is paramount. If you have an illness, you need to understand it and have the buy-in. Let's have our next question. I think we're getting near the end. Was that our last question? Okay. Yeah, last question. Okay, so we have a few moments remaining. We've got some questions from our attendees. I'm going to just shout these out first. So if hypomania is harmless, should it be treated? I want to answer that because I like that question. When I teach residents, I ask them, why are people afraid of shark fins? No one's ever been hurt by a fin. And the residents usually say, well, it's what comes after the fin that does you in. And so it's true, hypomanias in and of themselves are not dangerous. If they were, they'd be manias, right? So this, in some ways, is a question that's more pertinent to bipolar 2. If a hypomania were to evolve into a mania, then it's no longer harmless. So got to know what the patient has. Bipolar 1 and bipolar 2 are different. A bipolar 2 patient, by definition, doesn't have harmful manias. But both bipolar 1 and bipolar 2 patients who have a hypomania will almost inevitably go into a depression. And so it's not just that you're trying to treat the hypomania, I'd say, as much as you're trying to treat the switch process. You're trying to avert the evolution of the illness because it's undulatory. So it's not static. You're not just taking one moment in time. You're saying you're on the way up. What goes up is going to come down. Further thoughts?
I completely agree.
All right, next. How do you use the NNT, NNH numbers to inform your treatment decisions in patients with bipolar disorder? Roger?
Well, I use it as part of my discussion with patients when they ask about the likelihood of success and the likelihood of side effects. And it's always difficult to compare apples to apples when it comes to drugs, for example, in bipolar depression. But we have to have some metrics, and we do. And NNT allows me to look at the different agents that are FDA approved, next to each other, and then I make a determination based on that. What's the expectation of success? And then I look at the NNH around weight gain, around sedation, around diabetes, prolactin elevation, EPS, things like that. And this is a calculation. So I think it really allows us as clinicians to take that chaos of all that literature and have a very common language. What's the benefit? What's the burden? And how do they match? How do each option compare? Now, are these the only two variables? No. What did the person take before? What worked before? What's in the medicine cupboard? What do I have to sample? What can they access? All these things also matter, but clearly two major variables are what's the benefit and what's the burden.
And I guess I'll say it's a little like how you decide which horse to bet on based on what you know about its statistics. So if a certain candidate treatment has impressively outperformed a comparator or a placebo in prior studies, you might put your money on that candidate because it's proven itself to have value. Likewise, if a drug's been studied and found not to be efficacious, I mean, there are some second-generation antipsychotics, as we both know, that have, embarrassingly high NNTs, which means, if a drug has an NNT of 144, which one atypical antipsychotic does, it's not FDA approved for bipolar depression, that doesn't really help the first 143 people, right? So it brings down to odds, and having a single-digit NNT is just a kind of a reaffirmation of the efficacy. And then a high NNH by the same token. If I have to treat many, many, many people before some bad outcome will occur, I can impart more of a sense of confidence as I'm explaining why I want to pick this drug for my patient. Do you ever use antidepressant therapy when treating patients with bipolar disorder? There's that word "ever" again. Never say never. So yeah, I mean, you use a lot of things. I think the question is not do you use, but rather when might you use? And when I've thought about this, written about this, I frame it as the concept of candidacy. Just like you can think of candidacy for any drug, even lithium. Who's a candidate for an antidepressant? So, the good news is they exist. The bad news is there are not a lot of them. So a good candidate for an antidepressant, in my book, literally, would be a bipolar 2, not a bipolar 1, pure depressed, so no mixed features, pure depressed phase of illness with no recent mania, no rapid cycling, no comorbid substance use disorder, no history of ever having destabilized with an antidepressant in the past, as one of those case scenarios talked about before, preferably with a history of a good, robust initial response to an antidepressant without overshooting the mark. And if you're into pharmacogenetics, there's a little bit of research to say that if you happen to have been blessed with 2 copies of the long allele of the serotonin transporter gene, you might fare a little bit better. And at the end of the day, this boils down to a very small number of patients. So you're screening patients for candidacy, and if they hit those check marks, they might be a candidate for an antidepressant, but the great majority of patients are not. I'm going to ask you, Roger, to answer our last question before we are out of time. Besides the mood disorders questionnaire, are there any other screening tools or tactics to help determine casehood or likely casehood for bipolar depression?
There are. There's about half a dozen, Joe, that are widely, available. The ones that we're most familiar in North America, I think, is the MD-Cube, been with us for 20 years and counting, actually, a bit longer. And recently we validated the rapid mood screener, myself and my colleagues, which was an attempt to try and have a briefer scale, and a scale that we hoped could reduce some of the false positivity, which has sort of been a real problem with screening tools. A lot of folks tell me, screening tools, there's a lot of false positives. They diagnose or they screen, positive people when they don't really have bipolar, like borderline personality disorder or drug and alcohol misuse, anxiety and depression. And so the rapid mood screener. And again, a really important reminder, I said this during the program, a screen positive does not equal bipolar. A screen positive means please get rolled up and then you delve in to some of those, what we call illness validators. Joe mentioned it, I mentioned it, age at onset, number of episodes, response to antidepressants, family history, looking at patterns of comorbidity. And don't forget the phenomenology. I talked about the 4 A's, but also we think about atypical depression, lots of eating, lots of sleeping, and psychosis. So it is, in fact, I think a screen positive means you got to put your pen down, roll the sleeves up, and just delve in a little deeper.
And a screen negative is also very valuable. If a patient screens below the threshold, you may not spend as much time. So I've actually, in this COVID era, where time is of the essence, and I'm seeing patients, as many of us are, through the screen, I will send a packet ahead of time to the patient. And if they come back with a negative screen, I'll have a different mindset. If it comes back with a positive screen, that's going to frame my interview. So I see you identified the following symptoms. Let me follow up now and ask you about that. It's a time saver. And speaking of time, unfortunately, that is something we no longer have for us tonight. So that's all we have for time tonight. I want to thank everyone in our audience for joining us this evening. And those of you who are viewing on the live webcast, you will be immediately redirected to the evaluation form. For those who are viewing the live stream from a social media platform, you can claim your CME credits at integrityce.com/BP2 post test. I'll say that again, integrityce.com/BP2 post test. The link can also be found in the video description. Roger, it's been a pleasure as always.
Always a pleasure, John.
With you. We hope to see you all again live sometime soon. Stay safe, take care, and good night.